administrative assistant helping with the course today, and I'm glad you all could join us. Before we get to the presentation, I want to remind everyone of a few things. If you have questions or comments, please use the chat box or the Q&A features at the bottom of your screen. And also, please complete the evaluation for today's webinar so that we can improve future webinars. The link is in the chat box. And our next webinar in the fall series will take place on November 4th. And it is from statistical significance to clinical significance, time to dethrone or get rid of significance. And that will be presented by Dr. Lahana Thabain. And this one is rescheduled from September. Today's webinar is on optimizing clinical trial design in rare disease, presented by Dr. Quintana. And Dr. Quintana is a director and senior statistical scientist at Berry Consultants, where she specializes in designing Bayesian adaptive clinical trials across a wide range of therapeutic areas. And I want to thank Dr. Quintana for her time and presentation today.
Yeah, thank you. And given that we have a small group, Michelle or Will, if you guys want to monitor the chat, if there's questions, you can feel free to, interrupt me and ask questions as we go. Happy to answer questions as we go.
I will.
Sure.
I will.
Great.
We will do that. Cool.
Okay, good. So today I'm going to talk about optimizing clinical trial design, in particular with a focus on rare degenerative diseases. As was mentioned, I am a senior statistical scientist and director at Berry Consultants, where we design a wide range of innovative clinical trials across a wide range of therapeutic areas. I'm particularly interested in developing more innovative clinical trials in rare progressive diseases, and also in studying disease progression models for those diseases. So you'll see that today. I'm going to sort of start this discussion by talking about three separate case studies of three separate rare degenerative diseases in which we've worked to design clinical trials. The first one being GNE myopathy. So GNE myopathy is a rare genetic muscle disease, and how that occurs is it kind of starts in the ankles and in the muscles, and it slowly progresses to different muscle groups, and it's categorized by atrophy, and that those muscles sort of turn into fat. Patients sort of tend to present by tripping a bit more, so because their dorsiflexion or their muscles in their ankles don't work as well, they'll have foot drop and they'll start to trip, and that's kind of how it's first noticed. We were lucky enough to work with the Rare and Neglected Disease group at the NIH, who had this really nice, rich natural history database in which they studied individuals with GNE myopathy to see how they progressed over a course of different meaningful endpoints. They would bring them into the NIH for a couple of days and really take a lot of different measurements to understand how the disease progresses. And then the goal was, when that group came to us, is they actually had a treatment in which they wanted to test if it was able to slow decline of muscle strength or slow disease progression. And they wanted us to be able to design the most efficient trial possible to answer that question. And then the last thing I'll highlight is just down here, we can see sort of degeneration in this disease. This isn't the same subject. However, it is showing subjects at multiple stages of the disease. This one having a lot of the same, a lot of the muscle that you would expect in their lower extremities and hips, although this is kind of what it looks like towards the end of the disease when a lot of that muscle is atrophying and turning into fat. Another case study that I'll highlight is frontal temporal dementia. This is a form of dementia, but it results in progressive degeneration of the temporal and frontal lobes in the brain. Some forms of FTD have a genetic cause, about 10 to 20% of all FTD. And here we worked with groups at University of San Francisco, UCSF, Dr. Boxer there, who had a large observational data set of individuals with familial FTD, so they had genetic mutations. And he had this large observational database, again, looking at different outcome measures across the disease spectrum. Some are MRI measures, some are blood biomarkers, some being neuropsychological tests or cognitive tests, so a bunch of different measures over time. And also there was a group in the UK and the EU with a large database, and we actually developed a consortium between the two groups, took those two worldwide large databases, kind of combined them and tried to study how this disease progresses over time within the different genetic mutations. This is not the case study that I'm going to highlight today, but if you're interested in this one, I have references at the end. We just had a paper out in Nature Medicine to look at the temporal changes in frontal temporal dementia. Another case study that I'll highlight is that in dominantly inherited Alzheimer's. This is a rare genetic form of Alzheimer's. It occurs in less than 1% of the total Alzheimer's population, and it does have a very earlier age of onset. Typically, those start to present at about the same time that their parent, who also had dominantly inherited Alzheimer's, started to present. And we also, in this case, you'll see a common theme here, had this great observational data set where individuals at the University of Washington were studying how the individuals progressed over time, again, across a lot of different measures, brain measures, blood biomarkers, cognitive scores. The challenge in Alzheimer's, as I'm sure a lot of you are familiar, is that a lot of people believe that we're studying it too late, or we're treating it too late. So we're treating it more in this MCI or dementia phase, because that's how we can power our studies. Because to be able to discern if a treatment actually slows cognitive progression or not, we need to have some progression in the control group to see if there's actually a difference or not. So in history, we want to be able to power our trial, so we enroll those fast progressors. And what we're thinking now is maybe we're treating this too late. So the goal then really is to enroll sort of this preclinical phase where we still think we can help individuals. We're giving treatment early enough that we can sort of slow or stop progression, but we can still power our trials. So this dominantly inherited Alzheimer's group gives us that unique opportunity to do so, because these are individuals who will develop Alzheimer's, and we can predict when those symptoms might start to occur. In sporadic Alzheimer's, this would be much harder, although there are some prediction models out there that can try to help predict if somebody will get Alzheimer's and where those symptoms will start. So I gave these three examples because I think there's a lot of commonality across them. There's a lot of commonality in the complexities in designing clinical trials in these rare degenerative diseases. The first is, obviously, there's a lot of heterogeneity in progression. That might be due to the stage of disease that you're at, but that might just be due to differences in the disease. Also, the endpoints that we tend to look at have a lot of variability. So it might be measurement error. It might just be that the participant is doing better on one day than another, but lots of variability in the clinical endpoints, which isn't unique to this type and to these types of diseases. We see this all the time. Another part is that different endpoints might be affected at different stages of the disease. So in the GNE myopathy case, for instance, if we just were looking at dorsiflexion progression and seeing if we could stop that or slow that, we would be missing out on those who had already progressed on that endpoint and were moving on to be progressing on a different muscle group. Or in frontotemporal dementia, maybe we are looking at people who haven't yet started to show signs of neuropsychological degeneration. We may want to start looking more at brain imaging to see what we can see in that stage of the disease. So in these neurodegenerative diseases, there might not be a single endpoint in which it encapsulates the entire disease progression. So common solutions to this is that we can enroll a more homogeneous subset. And this is what I started to talk about with Alzheimer's and what we were doing. We were taking this very narrow range of fast progressors and enrolling those ones in the clinical trials so that we can power our study. Another common solution is to enroll a large enough sample size to overcome the heterogeneity. Now, both of these obviously are not ideal in the rare disease setting. If we're taking a rare disease and making it even more rare by enrolling only a small narrow window of it, that often will lead to not a feasible study design. Same goes for trying to power our studies with just thousands of patients to overcome any heterogeneity. Obviously not feasible in a rare disease setting. So lots of complexities that are common really across most situations, but really rare disease is the situation where we need to get creative because we can't use our normal tools in which we would try to overcome this heterogeneity. So solutions in rare disease, and I've touched on some of these already. What was common across these three case studies was the natural history study or the observational studies that individuals did before we even started thinking about clinical trial designs to test new therapies. These are really invaluable. It's really important in rare disease that we're not just throwing stuff at the wall and seeing what sticks, because we don't have a lot of resources. So it's really important that we know what we're working with. And we're able to do that through natural history studies and through building models and understanding the disease progression in terms of important clinical endpoints. And I'll dive into this a little bit to show you more specifics on how we did that in the GNE myopathy case. Outside of just knowing your disease better and knowing what you're working with, there are many solutions for innovative designs, and I'll just touch on a couple today. But there are ways to have more powerful analysis methods that use all available data. That might mean, if you have repeated measures, you use all of the longitudinal data instead of just doing a change from baseline at 2 years, t-test. It might mean using multiple endpoints in some sort of joint model. It could mean a lot of different things, but really think carefully and creatively about more powerful analysis approaches. Another area that was common to all three of these are adaptive designs. So adaptive designs allow us to change based on pre-specified rules throughout the course of the trial to see if we could potentially stop the study early, either for futility or efficacy. If we stop for futility, that's extremely beneficial because these limited resources can then be used to switch gears and study something else. And then finally, really think of all of the data that you have and how we can synthesize that a bit more and using all of the data that we have. So that might mean building synthetic controls from our natural history databases. It might mean in the case of the DIAN and the FTD trials, building what we call an adaptive platform trial, where a platform trial is this freestanding arena that's built with common rules that new drugs and new companies can come into the arena and test if their treatment works. This obviously, these approaches, which I'm not going to go into too much detail today, but these approaches can have many efficiencies, clearly operational efficiencies that the arena is built, it's already standing. You don't have to reinvent the wheel, but also there's inferential benefits. Oftentimes in platform trials, we can share data because it's all being enrolled under the same master protocol. So what we might do then is for each treatment tested, we might compare them to a shared control. And that can be really invaluable, especially in rare diseases, to build these sort of platforms to share information and to be able to test multiple hypotheses very efficiently. So that was just a sort of a crash course in all the things that I think we can do, or some solutions for rare disease. I want to dive a little bit more deeper into the GNE myopathy case and show you a few examples of what this might look like in practice. So first, let's start with natural history studies and knowing what we're working with and building disease progression models. So as I mentioned, in GNE myopathy, we were blessed to work with individuals at the NIH who had this really nice natural history data set. At the time of our publication, which I'll reference at the end, we had 38 participants in the database. They were being brought into the NIH and visits were being done every 3 to 6 months. And many different measurements were being taken, 6-minute walk tests, the different functional rating scales, as well as this measurement called the QMA, which was a quantitative muscle assessment for multiple muscle groups. So it's performed on different muscle groups to assess how strong you are on that muscle group. And just taking this data, you can do very simple things with this data. You don't have to go crazy and build some complex model with the data, but you can just start to really learn from it and make evidence-based decisions on your clinical trial design. So let's take, for instance, the 6-minute walk test. So here I have that plotted 6-minute walk test here. It's essentially the number of meters that you can walk in 6 minutes. I have that plotted for different individuals. The lines connect a single individual across the follow-up that we had. So you can see right away, lots of variability in what someone can do at baseline, even within the same disease. And then you also notice lots of measurement error here. You know, this individual started up, came all the way down, went back up. So that might be measurement error. That might just be a bad day. They were having a bad day and couldn't perform well. And then also you can clearly notice that so much variability, but very little progression over even the 36 months. So we're not seeing a lot of sensitivity to progression in this test. So what we can actually do is then just make some very simple summaries of this data. So what's the rate of progression over a year or 2 years? You know, simple things like what is the standard deviation within a subject? What's the standard deviation across subjects? And we can use those summaries from this data to say, okay, if I had a treatment that slowed progression on this endpoint by, let's say, 50%, what sample size would I need to power my study? So let's assume from the data that we create this summary of the red line is what a placebo will likely look like. The green line then would be 50% slowing in that for a treated subject. We would then need, if we just did a 1-year study, we can do very simple calculations to see that we would need over 1,000 participants to have 80% power. If we did a 2-year study, we see, okay, we need 300 participants to have 80% power. Both of these numbers really not feasible in the GNE myopathy population. We are thinking more like 50 to 80 individuals max that we would be able to feasibly enroll. I'll also note that this 50% reduction is pretty large. So oftentimes what a lot of individuals think in neurodegenerative diseases is that 30% is really, I don't know why that's the magic number, but ideally, if we could power a trial, we would want to do it at about 30% because that feels clinically meaningful to people. So even with this sort of larger treatment effect of 50% slowing, we would still need lots of subjects to power a trial on this endpoint. So you can do this with lots of different endpoints because we are collecting many. And again, these are very simple things that you can do to just have evidence-based design decisions and see if you're powered for different sort of endpoints. This endpoint, we did the same thing. You'll see it's oddly specific and you'll see why in a second. This is the upper extremity QMA. So this QMA is taken, as I told you, across a bunch of different muscles. This endpoint combined the upper extremities and also just looked at a subset of individuals. So doing this thing that we talked about earlier, let's just enroll this very narrow range of homogeneous patients. I believe it was patients who could walk some distance on the 6-minute walk test. We can see their raw scores in the natural history study over here, and we can get our power numbers again the same way we did before. What we saw is that on this endpoint, within this more homogeneous subset, we would need about 468 participants for a 1-year study and 120 participants for a 2-year study for 50% slowing in the disease. Now, why do I have this number circled here? And another number I'm placing on here is what's the power if we had 80 participants? That's about 21%. Why I have this number here is because during the course of this project, when we were working with the individuals at the NIH, Ultragenics was running a phase 3 study with this exact endpoint in this population. And the investigators at the NIH, rightfully so, said, well, they're doing this. This seems like this might be the right way to go. Could you calculate power for what you think their study is? And so we did that. And as I said, we got that we think their study has about 21% power. And then later came that the study did not show statistical significance. And I think in large part because it was underpowered. There wasn't on this endpoint within this population, it was very unlikely that they would be able to demonstrate even a 50% slowing in the disease. And that's extremely unfortunate, I think, in rare disease to have designed truly a failed trial here. Because we don't get many opportunities and we don't have many resources. So this is just a warning sign of really doing your homework and why that's so important to really understand what's the power of your study with reasonable clinical treatment effects under different situations. So again, as I said, we could look at many different endpoints that we collected in the natural history study. We did that across the board. We saw sample sizes all the way up to 778 for a 2-year trial. The lowest was about 96. So we're getting there with 96. That was for this AMAT total score. But of course, it's not just what endpoint can give me the best power. You need to have a regulatory endpoint and a patient-centered endpoint, one that matters to the patients. And it turns out that none of these single endpoints were really sensitive enough to run a feasible trial, although that AMAT got a little bit close. But also QMA was really determined to be the most direct measure of disease progression. It was determined that that could be a regulatory endpoint, and it was very patient-centered. Patients said, my disease is muscle degeneration. I think it is very important to measure the strength that I can maintain on my muscles. So it was the goal then, after we did, all of this work, very simple work, to better understand QMA and how it progresses on each of the muscles over the course of the disease. So not just a composite of the QMA or a single muscle of the QMA, but really how it evolves over the course of the disease and how the muscles change with respect to one another. Okay, so this is where disease progression models come in, and I'll try to highlight this at a very high level. Really, what's a disease progression model? A disease progression model is any mathematical function, and it aims to quantitatively capture individual disease evolution, doing so with either a single or multiple measures. So in this case, it's going to be multiple muscle groups of QMA. It's likely monotonic. That means, it goes in the same direction. We're not expecting that one muscle will decline and then start to increase back up again. And this is likely true in degenerative or progressive diseases. And then finally, ideally, we can model this as a function of disease stage. So here on this x-axis, you'll see what I call disease age and what we call disease age when we're building these models. We want to understand how the endpoints evolve over the entire course of the disease. But unfortunately, these measures aren't observed. We don't get to see a patient in clinic and know that they're 20 years from onset or know exactly, what disease stage they're in quantitatively. But our models can actually estimate them. There's ways to estimate them, and I'll go through that. And what are the benefits of a disease progression model? Why do we want to do this? Well, other than just really having a better understanding of the disease and the endpoints itself, they allow us to make informed decisions on clinical trials, and they allow us to build evidence-based clinical trial simulation. So you'll see this coming up, but in terms of designing innovative clinical trials, oftentimes very traditional power calculations don't work and can't be used. And so what we have to do is simulate the clinical trial. So actually simulate patient level data of patients coming in, simulate running the trial, and to get our operating characteristics such as power, type 1 error, things like that. Clinical trial simulation also has many other benefits in that it really allows you to stress test your design before you run it. So you can simulate millions of trials before you enroll a single real patient, which is really beneficial. And these disease progression models allow us to create evidence-based simulations. So when we simulate the data that goes into the clinical trial, it can be from a model, an informed model. Finally, these models allow us to predict future progression, and this might allow us to optimize clinical trial enrollment. So as we touched upon with the DIAN or Alzheimer's, it may allow us to enroll individuals who are very close to onset so that we can treat them early enough and who we're predicting are likely to start progressing relatively shortly so our trials can still be powered. These models can also be used for more powerful analysis methods, and you'll see that coming up. So back to QMA, just a little bit of more details regarding QMA. Again, this is a muscle test. It measures in kilograms the strength in which you exude when you're using a certain muscle group. It comes out again in kilograms when you perform it. We can do it on the left and right across multiple muscle groups, but then there's a nice publication to give predicted kilograms for a person of the same age, gender, and BMI. So we can take that measured kilogram and turn it into the percent predicted to see where are you? Like, is this relatively normal strength, or have you really started to degenerate on this endpoint? So you can see here for this individual in this one measurement, some of their upper extremities like grip, wrist, shoulder abduction, pretty normal. Also hip, pretty normal values. Dorsiflex, just as we talked about, is one of the first to progress. And so we start to see this individual having only 25% strength on that dorsiflexion. This is in the natural history database for GAD myopathy. This is just a snapshot from 4 subjects, but just to give you a sense of what the longitudinal data looks like. We have multiple muscle groups here, 6 primary muscle groups that we studied: knee flexion, which is the hamstring, ankle dorsiflexion, obviously the ankles, knee extension, which is the quadricep, grip, shoulder abduction, and elbow flexion. In this first subject, the 2 red and orange lines are completely on top of each other because this subject is completely progressed on their knee flexion and ankle dorsiflexion, and sort of actively progressing on grip, shoulder abduction, and elbow flexion. Subject B, around the same age as subject A, but still has some strength in their ankle dorsiflexion, is kind of actively progressing on that. C, more like A, almost fully progressed on knee flexion and ankle dorsiflexion, and actively progressing on shoulder and elbow. And then finally, subject D, very strong on almost every endpoint except completely progressed on the ankles. So just looking at this data told us certain things about what we had to consider in our models. One is that chronological age may not be a great predictor of disease stage. You notice subject A and B are similar ages, and subject A is much more progressed than subject B. Again, and then another thing is that we need to take into consideration some individuals are just stronger than other individuals, and then stronger than what you would expect them to be of the same age, gender, and BMI, like subject D here. So we need to account for this natural subject across subject variation in our models. So what's the goal of our disease progression model? Well, what it is we have a bunch of these snapshots of the disease, maybe short snapshots of a disease that we think could span 60 years. Each one provides a piece of the puzzle to what that entire disease evolution might look like. So subject A might define a piece of the puzzle for a more progressed participant, whereas subject B might find a piece of the puzzle for a less progressed participant. And so what our models do is kind of align individuals, move them left and right here to try to understand or estimate where they are in the disease spectrum, or where they are in their disease age that I told you is this unobserved variable. So we shift these individuals left and right. We can do this with all of the individuals, put all the pieces together, and then simultaneously estimate the entire disease evolution, especially across a large span of the disease, and then relative to one another. So I'm not going to go into too much of the statistical details of how we built this model. I'll share a publication with you if you wanted to dive in a bit more. But really, in the end, we're able to get this nice picture of which are the muscles that are likely progressing first. As I mentioned, it's likely dorsiflex, followed then by knee flexion, and which muscles don't really tend to progress too quickly. So the knee extension here remains relatively flat. That's the quadriceps. And this had a lot of face validity to it. This disease was initially called the quadriceps sparing disorder. So it was known that for some reason, maybe it's because it's such a large muscle, that we're still able to maintain a good amount of strength on that muscle group throughout the course of the disease. Finally, the other thing that we can do once we build these models is take these disease ages that we're estimating for each of the patients in the natural history study, and then look at other endpoints as well for those individuals. So we might say, okay, of people who were all around the disease age of 0, we understand, knee flex tends to be around 50%, shoulder abduction around 50%, ankle dorsiflexion, completely progressed here. But what does this mean functionally? And so when we relate these back to those other functional endpoints that we took, we can see, well, what tends to be for a subject of this disease age is that they tend to intermittently use a handrail when climbing the stairs, but they're still able to climb the stairs. They might have some mild unsteadiness when walking, but they're still able to do so. When they're trying to go from sitting to standing, they may use some substitute motions to do that. The 6-minute walk test is approximately, they can complete 450 meters, and they're on the AMAT high functioning group. Now we can compare that to what does it look like when we're at disease age 30 years later into the disease. Well, now we're almost completely progressed on all the muscles except the knee extension. This likely then corresponds to requiring the handrail or some sort of additional support to climb the stairs. They're likely dependent on a device to walk. They have great difficulty turning in bed. They need help with fine motor tasks such as cutting food and handling utensils. And they have to have some modified techniques to dress themselves, and then completely not able to complete the 6-minute walk test. So you can get a sense from this disease progression model, not just of QMA, but also of how those different disease stages relate back to the functional outcome measures as well. So these disease progression models really allow us to have a good understanding of the disease itself. Okay, the other main reason that we were building this disease progression model is to allow it to inform our clinical trial design, so create these realistic clinical trial simulations that I was telling you about, and B, can we actually use this model that we built, this disease progression model, to analyze our data? Can we use it in some way to say, okay, this is what individuals will likely look like under placebo, and now I have a treated patient and their evolution is a little bit different than that. And so is that evidence towards a treatment? So we're going to look at that part of this now. Clinical trial simulation. So I touched on this a little bit at the start. The goal of clinical trial simulation is really to understand the operating characteristics of a proposed design, to be able to iterate on a proposed design and optimize it under key trial parameters such as sample size, length of follow-up, who you want to enroll, what's the primary endpoint, what's the primary analysis. You can really do anything with clinical trial simulation. The other extremely important benefit of clinical trial simulation is that you can simulate single example trials. I'll show you data that, I simulate patient level data, say of 50 patients. I'm going to enroll 50 patients. I simulate all of their longitudinal patient level data. I run it through the proposed analysis method, and I show you what that looks like. And this can be extremely important when you're trying to get buy-in from a diverse set of stakeholders on potentially doing an innovative analysis method or an innovative design, that they're able to see how the trial will run and how the analysis method will work very clearly before you even run the trial. So that's a major part of this that can also be extremely beneficial. So how do we actually do clinical trial simulations? I'll walk you through this a little bit. We start with that historical data, and oftentimes we build a model. Okay, check. We've already done that, and we've already walked through that. We use that model then to create these realistic patient level data simulations, or simulated patient level data. We run that through our design or our analysis method, and we might do this process, a single time to show, what the results might look like to our collaborators, or we might do this thousands of times to show the power of operating characteristics. So here, when we start, this is just a little demonstration of what this might look like. Here, let's remember, what if we want to simulate data on knee flex? Let's say this is our primary endpoint. Here is the mean progression for knee flexion over the course of the disease age that we estimated from our disease progression model. So on average, we think that placebo patients will follow this progression. So let's say the first subject comes in. I want to enroll them, and I want to predict or estimate or simulate their data, what that might look like in the trial. Well, we know there's some variability to subjects. So instead of following this black line, this one is a little stronger than most. So we think they'll follow this black dotted line. When do we enroll them? We don't get to observe this entire follow-up from -10 all the way out to 20. We're not following them for 30 years. We actually happen to enroll them when they were at disease age 0. So right here. So over the course of, say, a 2-year trial, we would think they would follow this black dotted line. However, we enrolled them to the treatment group, and we actually are simulating under the assumption that this treatment works. So instead of the black line, we actually think they're going to follow this blue line on average. And then we also have some understanding of measurement error or variability. So we can sample around this blue line with some sort of measurement error and get the following trajectories. So what we would actually observe in our clinical trial, say we're doing a 2-year trial, is the following data. Measurements around 60% for knee flex. We can do this again for another subject. This is a placebo subject. We enrolled them about 5 years post onset, disease age 5. This is an individual who had a little bit less strength than the average person on this muscle. And we record their values a little bit below 20% across them. We can do this with all the patients we plan to enroll in the trial, black and the blue patients, and we can start to get some summaries. So here we might start to look at the mean change from baseline for the blue patients relative to the black. And then we might have a very simple analysis method that is a t-test and the change from baseline at 2 years. And we do that test. We say, was it significant or not? And we learn from this single simulated trial, okay, this is what the data looked like, and yes, this t-test was significant. To get operating characteristics, we can do this thousands of times. So I'm going to do this simulation process thousands of times with the proposed sample size, follow-up, primary analysis, and I can understand what are the proportion of these that would actually be successful at the end. And that gives us an estimate of our power. It can also give us estimates of, is our model accounting for completely capturing appropriately the treatment effects. So it could give us estimates of bias if there is some bias with our analysis method. And it can give us a lot of different sort of operating characteristics of our design. So we did this process with a proposed trial that the individuals at the NIH had. The proposal was to enroll 51 participants, randomized 2-to-1 treatment versus control, have a 2-year study, 30% slowing in progression. And when we did this and we looked at lots of single endpoints, so back to that table that we showed earlier, or simple analyses of these QMAs, what we saw is that we had about 10 to 40% power, depending on the endpoint or analysis for this study. So great. We did all of this work. We really believe our simulations are evidence-based, and we discovered that our study is underpowered and we don't think we can increase sample size. So what can we do? So this is where it comes in with, especially in rare disease, you can't just trudge forward saying, this is the feasible number. These are the only options I have for the endpoint. So I'm just going to see what sticks. We're going to run an underpowered trial. This is where we really need to be more creative and invest in innovation. So the thought here was using that disease progression model that we had to actually use it as an analysis tool. So first, we might, again, see some simulated data, this gray data, and this blue subject might be a treated subject. So if we just looked at sort of their length of follow-up, it's really hard to tell if this blue subject progressed more slowly than the gray subjects. There's just so much variability here. So the first thing we can do is use the concept that we had in the disease progression model to estimate disease age and to account for disease stage in our analysis itself. So we might have placebo data like this, but when we use a model with this sort of latent disease age, we could estimate, okay, some of this variability is actually due to the fact that these individuals were just at an earlier stage of the disease, and these individuals were at a later stage of the disease. So we can see a clear pattern in the data already. Now, if we overlay that same blue patient who just looked like they were in the middle of a bunch of noise here in this analysis method, we can now start to see, even from eyeballing, that there might be some evidence here that this patient is progressing more slowly than the same counterparts who were on placebo. We think they're probably about 5 years from onset, and all of the other gray individuals or gray data points that were at that same disease age never really stayed at a value over here. They all progressed a bit more. So already just by eyeballing, you can see why just adjusting for disease stage in your analysis might be a good idea and might give you added power. The second thing is we talked about this earlier, multiple endpoints are affected at different stages of the disease. And if we want to enroll this broad patient population that might be at different stages, it's extremely important that we incorporate different muscle groups or all muscle groups. So model those jointly. So here's an example of this, even with our analysis method where we can adjust for disease age. If we would have enrolled somebody, disease age, say -5, and treated them, this area, there's not likely a lot of progression on NEFLEX, and there tends to be a lot of measurement error in that portion of the disease stage. So NEFLEXion might not be a great endpoint to look at for this type of subject. However, if you looked at their dorsiflexion, they're likely actively progressing on that right now. And the other placebo patients are likely actively progressing at a very quick rate. So if you looked instead at dorsiflexion you can see some evidence that this individual is progressing a little bit more slowly than the other individuals. So this is just an illustration of why we think using these sort of models may be more powerful. Because they explain some of the heterogeneity and you can more clearly see if somebody is slower than than what they're expected to be, and B, because we use multiple endpoints, so we can really enroll that broader population and use the endpoint that's most appropriate for them. So that's exactly what we do. I won't go too much into detail here. In our GNE, what we call disease progression model analysis. And when we did our clinical trial simulations using this type of analysis, this joint model, we went from 10 to 40% power all the way up to greater than 80% power. So again, this might seem like magic, statistical magic. I hope you just seeing the illustrations before show that it's not magic. It's just being more thoughtful about the data and using all the data that you have at hand and doing that in a more efficient and thoughtful way. So to save time for some questions, I'll sort of wrap up here, show a summary. Really, if you haven't gotten anything else out of this talk, I think the main point is run a natural history study or try to get some data on the disease in which you're studying and just make more informed trial design decisions. That allowed us to understand that with very traditional endpoints and under a feasible trial design, our power was very low and we would not have much power for those types of studies. The second point I'll make is use all available data that you have at hand. That might mean multiple endpoints, that might mean using all the follow-up, that might mean adjusting for disease stage. And in doing so, you can really create a lot more power and a lot more of an efficient design. That being said, this should go with some advice. Advice would be when you're developing these innovative approaches, it's extremely important to speak with partners early and often. So regulatory agencies, patients even, it's important that they understand the innovations that are happening here. Clinicians, whoever you're talking to, it's important that you speak with them early and often. And clinical trial simulation can actually be very helpful to try to get buy-in from this diverse set of stakeholders. Again, natural history data in the clinical trial simulation is a way to really get that buy-in. And then the last thing I'll just say is take the time to invest in innovation and take the time to know what you're working with. So it might take more work up front. Certainly this trial probably took longer to design than just running to a statistician and saying like, can you give me the sample size for a t-test for this endpoint? But because of that, we have a well-powered study and a very thoughtful approach. So it's very important, I can't say enough, to really invest in innovation. That might mean allowing more time to consult with statisticians. That might mean needing to find funding to get a statistician on board for the design planning. But it's really important and really crucial. And I'll just end with some references, and I know we can pass these slides around and you'll have access to these references, and I'll see if there's any questions.
Thank you, Dr. Quintana. It was interesting. I think when one of the clinicians who was working to plan this trial came to a conference we put on adaptive designs that Scott Berry was at, I mean, she literally said she talked to like 30 statisticians about how to approach this trial and basically was told by all 30 that there was simply no way to do it. So I think, this represents a huge amount of work, but also a way to kind of not take no for an answer for an important disease, to come up with a tailored solution that yes was hard, but the alternative was throwing up one's hands and saying that this isn't, this is a disease that we can't learn about new treatments for. So I think this is just really a tremendous example of linking clinical problems to innovative ideas and innovative thinkers. That's not a question. I guess that was just me gushing. But Dr. Conwit does have a question regarding how is recruitment going in that trial, and when there may be some results available, if you know.
Yeah, recruitment is going good. I think it's on target. It did take a while to start, but it's on target now that it's started. I believe it's on target. It's a 2-year study, and because it took so much work up front to find an analysis method that was well powered, we actually did not build in adaptations for that study. So once we get everyone recruited, it will then be 2 years of follow-up on everyone before that trial reads out. So it will be a bit of time still, but luckily we feel that we're not just doing it in vain.
Another question from Elizabeth Van Sickle. Do you know if there are any disease progression models for ultra rare diseases, or if there are other innovative ways to model progression in diseases with very few identified individuals, less than 50 known individuals?
Oh, good question. Sure. I mean, I think there has to, I personally haven't been involved in ultra rare disease. I'm trying to think if I have. I don't think so. But I would certainly say, you know, if you have data on 2 patients, it's important to look at. If you have data on three of those 50, it's important to look at. So we get asked this question a lot, like what's the minimal sample size that you would be willing to explore in one. So I'm happy to look at data from 1 patient. I think that's better than none. So I would say, you know, maybe we can't do as complex of modeling, but we could still do very simple things to try to better understand the disease and try to make evidence-based decisions on clinical trial design.
Yeah, and I mean, that's something that sometimes comes up in our clinical trials course about, you know, the potential, you know, particularly for something that is like a rare disease with few treatments, but that is something that is progressive. You know, if you have a good way of measuring, you know, objectively, you know, the problem here, you have all of these muscle groups that can be measured in details. But in another condition, if you can, you know, if you have something that really, you know, can quantitatively track the progression of disease, sometimes like N of 1 designs can be considered. And we even had somebody who you know, you can do like a meta-analysis of N of 1 trials to start to come up with a, you know, sort of estimated kind of combined treatment effect, to sort of figure out, you know, which treatments are actually beneficial in those cases. So I think that's something though that it's very, you have to talk to the right people who have the right sort of mindset from a biostatistical perspective, but sort of ask in the right ways of, you know, we probably will need to do something relatively innovative or novel, because this is a rare disease. But I think it's so important to do science in such a way that you can learn on behalf of these patients, and then on, you know, but also to think about these methods. And it looks like the G&E myopathy trial had about 51.
Yeah, the trial itself is small. I would say rare. The disease itself, I don't know the exact definition of ultra rare, but I mean, that natural history study, I can't speak enough about it. I mean, they were literally flying individuals, the known individuals with G&E myopathy, in from all countries. So they would fly them into the NIH. It had to take an extreme amount of work to be able to do that. So there are still things you can do and try to do.
All right. I think we greatly thank you for coming to present today. I don't think we have any other questions. Michelle, did you have any parting comments?
Please remember to fill out the evaluation. The link is in the chat. And thank you, Dr. Quintana, again for joining us today.
Yeah, thank you, everyone.
All right. Bye, everybody.
Bye-bye.
Bye.